whereas patients with, treated with placebo had a worse outcome. And again, you see that when you stratify for presence of anti-CCP, then the difference was in that subgroup, which means that if you have a patient with joint swelling and positive anti-CCP, then you should start with methotrexate. So this is really rather new knowledge, which was not present before, but is also incorporated in the thinking of the new classification criteria of rheumatoid arthritis. And the same also for radiographic progression. The differentiation between methotrexate and placebo was seen in the patients with undifferentiated arthritis that were anti-CCP positive. I'm not going to mention very much about the biological agents, but of course it is very important that we have now access to the TNF inhibitors, but also that we have access to other mechanisms of actions, like targeting interleukin-6, B cells, and T cells. So I think that the essential message here is perhaps, if we look at the upper part here, for example, easiest to see, that if you randomize the patients to methotrexate alone, then you have more radiographic progression than if you are using adalimumab alone, than if you are using adalimumab in combination with methotrexate. So the key message is that also these biological agents, they are much more effective if you combine with methotrexate than if you use monotherapy. So if you had been looking at clinical endpoints, there are actually very small differences between methotrexate and monotherapy of TNF inhibitors. So when you look, for example, into cost effectiveness, I think it's very difficult to find that monotherapy with anti-TNF is really cost effective, but that other TNF inhibitors in combination with methotrexate are much more effective. What we found rather early, because I'm from a country where we are fortunate and had access to these drugs very early, so we also started to use early in spondyloarthritis. So we were able to show that actually the health benefit measured here on health-related quality of life was larger in patients with ankylosing spondylitis than in patients with rheumatoid arthritis. That's also what I think we experience in daily clinical practice. Some patients with ankylosing spondylitis, they are really the excellent responders to TNF inhibitors. Another important aspect that we have been focusing more and more on, and the next speaker, she was one of the pioneers in the focus on cardiovascular outcomes in rheumatic diseases. And I just mentioned this paper, which perhaps is not the highest level of science, but it's at least a politically important paper, because it highlights actually that the risk of cardiovascular disease in patients with rheumatoid arthritis is close to being similar to type 2 diabetes. So that also highlights that we as rheumatologists should in the future have much more focus on cardiovascular complications in the patients with inflammatory joint diseases. And that's why also EULAR set up a task force to make evidence-based recommendations for cardiovascular risk management in patients with RA and other inflammatory arthritis. So if we then end this to ask, do we really see health benefits in populations of RA after all these achievements that we have done with access to new therapies and more aggressive treatment? And the answer to that is yes, because everyone in the audience, being as old as me and starting with their jobs in the 70s and 80s, we saw a lot of patients with very disabling rheumatoid arthritis. The disease is definitely less disabling now. And that's also what we have found in our Oslo Rheumatoid Arthritis Register. If you look at levels of physical disability in 1994, 96, 2001, 2004, and data were also presented from 2009 at EULAR last summer, and then you see that there is a huge improvement in the level of disability over these years, and especially during the last decade, reflecting both that we are using more drugs, more traditional DMARDs, but also, of course, biological agents, and we are treating earlier. But the real, I think, for the next decade is, of course, to try to reduce the inequality of healthcare. And we saw data that Thiel Ulig showed you earlier today, that there are huge disparities in Europe across different countries regarding disease activity, and also that there is a relationship between disease activity and gross domestic product. So that means that there are different access to therapies across different countries in Europe. So I think that This political agenda is particularly important, so we as doctors, we should not only be focused on the medical affairs, but also have a wider perspective in our thinking. So what I expect in the decade, so I was thinking a decade starts actually perhaps in 2011, but development of new drugs, I think we will see more biological agents. We will also see some small molecules, and hopefully we will also have better drugs for systemic connective tissue diseases, and importantly for osteoarthritis and pain management. I think we will have that. I think we will have an even stronger focus on strategies and management program, including quality indicators, because healthcare in oncology becomes more and more expensive, and that means also that the political decision makers, they will request more data to see what we really achieve with our treatment. I also expect that we will have further development in imaging modalities. I haven't talked very much about ultrasonography, which is actually a very important tool in clinical practice and research, and I guess that within the next years, you will have on your iPod, you can connect it to some sort of detector, and then you will have, that will be your ultrasonography machine, perhaps in the future. Handheld ultrasonography devices, that's what will be expected. I think also that perhaps imaging will be included as treatment targets, and personalized medicine will be more and more focused to identify the patients who should have what kind of treatment when you start. And for that we will use clinical markers, soluble biomarkers, genetic factors, and other variables I expect. And I also expect that we will have a stronger focus on cardiovascular risk factors and assessment in the future. We have actually now a cardiologist working in the rheumatology department, and I think that that will probably be more and more important in the future. So thank you very much for your attention.